I was asked to come and talk to you about moist. That was the exact request. Would you come and speak to people at a decontamination meeting about moist? No context, no moist transportation, just moist. And I was like, let me just check that you are asking me to do what I think you're asking me to do, because I could agree to something completely different, and this could be a very different session. So hopefully I'm going to talk about the right kind of moist, and it's not going to go horribly wrong and outside everybody's expectations. So, I've been kind of working in this area, which, by the way, I don't consider myself an expert in moist. I feel like it's a fairly niche field. There are people who are potentially interested in it. So, maybe in terms of the number of people who will claim to be interested in moist, I am possibly one of the few. But I think it's a really interesting thing, because when I started doing this work, which was probably like 2010 with the Department of Health, I used to do it with two amazing women, Margaret Hollis and Sylvia Chagra, and I would be in the middle, and Margaret would be Mrs. Moist, and Sylvia would be Mrs. Dry, and it was a very bizarre session, I can tell you, and I almost miss having them here, because I felt like there was like strength and power in numbers, but you've just got me now. It would be useful for me to know what kinds of professional backgrounds we have in the room, because if you're like me, you may wear many hats. So I work in infection control as an infection control doctor. I was trained as a clinical microbiologist. I kind of go and do decon stuff because I find it really interesting and scientifically engaging, but it would be nice to know kind of what backgrounds we have. I kind of wish I'd asked for, I'm intrigued as to other. If anyone's an other, do you want to shout out who you are? Anyone? One of you can be dry and one of you can be moist, and we'll have like a whole team thing going on. Thank you for that. And so we've got quite a spread, and I think that's probably quite normal. I think that's something we see a lot in decon committee meetings and stuff, and the kinds of areas where we're having these discussions about whether we want to move to moist transportation or not. We're going to talk a little bit about what is cleaning. My husband always finds this hilarious because I lecture across the globe on cleaning, and he's like, you're the only person who lectures on cleaning who has never cleaned her own house. Like, he finds the irony like quite full on. We're going to talk a little bit about biocontamination, what that looks like, why drying is a thing, a little bit about prion disease, and a little bit about kind of why we use moist transportation and the different kinds of ways that you can use it. Because this is a workshop, I've tried to make it vaguely interactive. I hope this does not bore you all to tears, so just forgive me if it does. Because a workshop for me means that it isn't just me sharing, it's about us kind of giving back and forth. It's quite useful to think about what kind of moist transportation you use. And I think the reason that this session is coming up now is there are big conversations in the States about whether to go with moist transportation or not, and whether to go with things like keeping stuff moist. Because they're in a similar position to where we were a few years ago, where we used to all have our SSDs on site, right? And so you used to walk them down and you had quite a lot of control about what happened. They're now also moving to big central SSDs, and when you're doing that, obviously you give up a certain amount of control in terms of that process, and you accept that you have longer turnaround times, and you accept that you don't have so much control over the temperature that stuff's going to be at if it's sitting in a van in 40-degree heat for 4 hours stuck on the M5, like some of ours are. So it's an important thing to discuss. It's an important thing to kind of know your risks about, and it's not just about prion disease. So I think that's what a lot of people recognize this in terms of topic as being linked to, but because prion disease is kind of one of the big drivers in terms of NICE guidance, it's quite a big driver in terms of the HTMs. There are other factors to why you might want to consider moist transportation, and we'll talk a little bit about those in general. So it's interesting, quite a lot of us are still dry. I say that's interesting because I only managed to, bear in mind that I used to sit and work with Mrs. Moist, we were moist, and then we stopped being moist because our central sterilising department moved off-site, and we've only just managed to move back to being moist because it does have a lot of logistical components that can make it more challenging. I deliberately keep using the word moist, and I do it because, slightly tongue-in-cheek, I know quite a lot of people don't like it. I kind of feel like the more I force people to say it and engage with it, the quicker we'll get over this hump. So I'm just quite intrigued about how do people feel about the word? Because I've sat in decontamination committee meetings where every time I opened my mouth, I felt like people were going to run for the door in terms of the fact that it just made them feel uncomfortable. And there isn't really a better word for it. Quite like both the words fungus and slippery. In my head, they are going to a very special place, so that's very amusing to me. Anthony. Are you very moist, Anthony? I don't know that that's a question I'm allowed to ask you in public, but slightly intrigued. Is there something I should know? Do you want to declare it to the group? Yeah, I think it's an interesting word that's quite evocative. And I sometimes think that one of the reasons that we had so much challenge with things like engaging people in this as a topic is that the very language we use turns people off. I do not have a solution for this because this is the word that is now embedded in guidance. Like, we are way past the point where I can go, shall we choose a different word, like humid? That is slightly less horrifying to many people. But, like, that ship has sailed. We are stuck with moist. But it is quite useful for us to think about it. Yeah, strange. I also love the person who said love it, because I'm with them. And I love the fact that it's in pink that you love it, because I feel like that basically sums up who I am as a person. So, in terms of the purpose of cleaning, we have all of the Spalding guidance about what levels of clean are needed if you're implanting something into somebody, if you're breaching a skin barrier. So there's all that about the level of clean, of sterilization that we require. But at its very fundamental level, what we're trying to do is to remove biocontamination. We say biocontamination, it's a fancy word, but basically all the blood, uck, and other stuff that is going to get on those instruments. And that will vary between surgeries, it will vary between patient type, it will vary between the colonization and other organisms the patient has on board. If you're doing something with pus, it's going to be quite different to if you're doing a shunt, right? It's just going to be different, and we have to bear that in mind. The risks are not universal across all of the things that we do. The one about reducing corrosion is really interesting to me, and I'll come on to that a little bit more. If you have salts on something, then you have a higher risk of rust and other processes, right? It's just chemistry. Biocontaminants will have things like salts within them. You kind of try removing them. We're going to talk a bit about dry biofilm. Put your hands up if you've ever heard the term dry biofilm. So lots of people have heard of biofilm. Dry biofilm is the same but slightly different. And we're going to talk about reducing the risk of hydrophobic proteins. So that's kind of your prion bit. And when it comes down to it, it isn't as complicated. Like, I can talk to you for hours because I'm that kind of geek about the science behind some of this stuff. But, and I don't do this because I think we've established that I don't clean. And my husband does it all, and he's amazing. But many of us will soak dishes at home, right? You take something out of the oven, it's got stuff baked onto it, you stick it in your sink, you add some fairy liquid and some surfactant, and you leave it to soak before you then try and clean it. Fundamentally, this stuff is the same, right? You can call it really fancy stuff, but basically we're doing the equivalent of adding fairy liquid onto something with some water and then trying to keep it wet so that it doesn't dry on anymore. The process, though, can look different. So we're going to talk a little bit about the process behind it. I went down some very strange rabbit holes, I have to say, on Sunday afternoon for this talk. You would not believe the number of Instagram and TikTok posts I watched on things drying. Some of it I don't think I will ever unsee, and I'm not sure there's enough money in the NHS for the therapy linked to what I saw. Because I was like, okay, now I've seen that, I can't unsee it, and I cannot move along. This one came from a forensic paper about blood in crime scenes. But it was the best thing that I could find that talks to you about how blood dries. Because in microbiology and infection control, weirdly, you don't get that many papers on blood drying. Apparently it's quite a niche field. But the important thing to know is that even at that macroscopic level that we can see, stuff changes as it dries. And as it goes through that process, it changes its chemical composition. Therefore, what you end up with is not the same as what you started with. And some of that is moisture removal, some of that is amino acid change, and we'll talk a little bit more about that. But the coagulation and the gelatinization that happens over that window where we're normally thinking about having stuff sat in a lorry or having stuff sat waiting to be picked up in theatres is a process that there aren't that many ways to change it. There aren't that many options for how we're going to do it. You could all decide to wash your instruments as soon as you finish your surgery. There are apparently lots of pieces of guidance that suggest you do that. I think if I tried to suggest that to my theatre staff, I might actually have a full-on riot. I don't think anyone's going to be volunteering, and I also don't think I have the space to do it. So if you acknowledge that that's the case, then we have to think something different. And the landscape has changed. The landscape has changed whilst I've been doing this. I used to have a lovely sterile services department on site. It was amazing. I used to pop down and go, oops, could you do this for me? Oops, that's really urgent. I have no one I can go, oops, to anymore. If I phone up my external guys, they're like, is that in your SLA? And I'm like, but it was just an oops. Please don't charge me for my oops. Accept my oops, love me for my oops, and please do the thing I need you to do. It's really different when it's not your service, and it's all about contractual turnaround times. It's much more formalised. If I get a van that breaks down, I'm in a central London hospital, it could sit there for hours in traffic. And so there are all kinds of things going on that I can't control. The instrument complexity has changed. I kind of also hope that we have a little bit, and I'm saying only a little because I really don't feel like I have a lot, more control on what some of my surgeons use and do. So when I started, there would be a lot of, I'm turning up with my favourite instrument and this is what I'm going to use it for. And you're like, please don't do that. Please don't do that. I have no idea where that's been. And it's like something you've made at home for this particular surgery. Please don't use that. I feel like we cracked down quite a lot on some of that home DIY version of surgical instrumentation, which has helped us, but also the general level of complexity of some of the instruments we're using is just so much more than we used to have. And as you increase complexity, you increase surface dynamics, you increase all of the hinges and difficult bits to clean. We have a lot of different instruments that are made of different types of materials, all of which will react in different ways. And so even if the instruments are the same, the underlying composition of those instruments can be different, and how they react to all of those extra chemistries can be different. And so it can make it hard to really be able to predict how different things are going to happen. especially if you're having drying and then you're trying to choose a cleaning agent that will work. When I started my career, I think that I feel a bit old. I'm not that old. I've only been doing this for 20 years, right? I'm still in my 40s, people. There's still hope for me yet. But we were still in an evolving prion scenario, right, in terms of understanding our knowledge. And that's because the incubation period is decades for some of these presentations. And actually, it's more complex than that, in that the thing that we think of as a prion presentation may not even be a prion presentation now. So when we're thinking about heterozygous presentation, heterozygous proteins, all of those different things, then actually we don't understand the disease process very well. And so as we learn more about it, we flex, we change, we make different decisions, we make different risk assessments. But that means we're living in a space where those decisions and risk assessments are ongoing. And so the decision that I made 10 years ago is probably not going to be the decision I make in 10 years' time, because we'll know more. And so we have to be able to flex as that risk assessment changes. And so that has changed from when I started. And papers on dry biofilm, I think, probably only started coming out about 5 years ago. Right? You have to roll with the science. Because this stuff, although I think it's sexy and moist, is not necessarily considered to be that interesting by the greater good, right? And so we don't make progress at the same rate as if you've got hundreds of thousands of research groups looking at this stuff, right? We still have and live in a country where a standard of clean is visual inspection, despite the fact that microorganisms have the fact you can't see them in the name. And so how we do that assessment and learning, it's still a really ongoing challenge. So we're going to talk about instrument integrity very, very briefly, and I'm raising it because of the fact that one of the reasons we stopped using moist transportation is this. So, corrosion and degradation, and it was all blamed on the fact that we were keeping things moist. And a lot of our surgical staff were like, you're keeping stuff moist, therefore you're increasing the risk of rust, because they associate rust with water and humidity. Whereas actually, corrosion is linked to salts and other surface processes, right? And so one of the reasons that you try to use, and a lot of people initially, before all of the prion stuff came out, were talking about moist transportation, was to try to stop salt-based corrosion on instruments. But I don't think we have that conversation particularly well with people. So even last year, when we tried to bring moist back in, I had a surgical sister who outright refused to do it, because she's like, you'll cost me more because I'm going to have to change my instruments more. And in order to reassure her, I had to start this whole surveillance audit process, looking at corrosion rates before and after the switch. Because we don't talk about it, we impose it. And if you don't have the ability to have the conversation about actually what is the underlying physical process that leads to this type of instrument corrosion, this type of instrument degradation, then you can't bring people with you on the journey. And there's some interesting papers out there that basically show that even those places that think they're transporting stuff moist, only about 57% of the instruments actually are. And that's because to get it done, you have to have somebody who's there who's actually physically going to do the process. And if they don't believe in it, they're not engaged in it, they don't understand what they're doing or why they're doing it, they're not going to do it in the way that you believe, that you've written your beautiful SOP. And I can tell you my SOPs are beautiful. I love them. I spend a lot of time on them. It doesn't matter how pretty they are or how referenced they are. No one's ever going to Google my references. It's not going to happen. So I have to sit there and talk to them about why they're doing what they're doing. Biofilm. So most people know about kind of wet biofilm, right? So that's the kind of stuff that you can see around your plug's hole if you don't have a husband like mine who cleans beautifully, in order to make things look much nicer. So all of that kind of slightly gunky stuff where you get organisms build up that you then can remove by cleaning. So we think about that in terms of like that visible contamination. What we're talking about with the kind of biofilm you're talking about for surgical instruments is this. So this is dry biofilm, so you can't really see it. This is a paper on kind of standard surfaces, so like the bottom left is like a chair surface, so you can see that kind of the scale that you're looking for. And this is SEM footage, so scanning electron microscopy. Now, you're like, well, if it's dry, what's it doing? It's not really hurting anybody. The problem is, once you get these layers of biofilm buildup, you're not getting penetration of your cleaning agents. So you're not going to get removal. You'll just get build-up of this biofilm. Now, dry biofilm can become moist biofilm if it gets rehydrated. So if you have it there, and you're not removing it, and you're not preventing it building up, then actually what can happen is, depending on a series of unfortunate events which you probably won't know have occurred, you can get rehydrolyzation of this biofilm, which then means that it will come off, potentially into a patient. It will also have all kinds of other things like endotoxins associated with it. It could have LPS, so stuff that actually triggers a chemical toxigenic reaction within your patient. And so the other thing to really bear in mind is you won't be able to detect it. Depending on how you use your protein testing, anything that relies on eluting off a surgical instrument, this is stuck. This ain't coming off. So if you don't measure directly onto your instrument, you're not going to detect that this exists. And because this has a layer of kind of gloopy protein on top of it, you may not actually be accurately able to judge how much of it is there. So a lot of our quantification stuff then becomes challenging because you don't really understand what you've got in front of you. So by maintaining stuff moist, you try to maintain the fact that you're not going to get this dry biofilm buildup. But obviously the big one that everyone thinks about is protein. And obviously biofilm and protein are associated, but they are not the same thing. So why do proteins matter? So they matter for a number of reasons. They matter because, as I mentioned, they can trigger immunological responses. So if you get greater than 8 micrograms per centimeter square, they can start triggering cell death. But also in patients, you might not even realize that the protein load is what's causing the issue. So they can trigger localized inflammatory response of a whole variety of things, which can impact on wound healing and other things. You can get it from numerous sources. So you can get it from your microbiological contamination. You can get it from the fact that you've just done a really bloody C-section and there's loads and loads of blood present that you haven't managed to fully remove. But you can also get it from things like residual cleaning agents. So enzymatic cleaning is actually really important in order to remove prions. So alkaline-based enzymatic cleaners are the best for removing prions. They have the word enzyme in them for a reason, and enzymes are proteins. So if you don't remove your cleaning agent, then actually you can end up with a problem, which is why making sure that all of that washer-disinfector process is really good, accurate, and appropriate is really important. And they can, as I said, be transferable between patients, if not well removed. And so that in itself can present a risk. Before we go on to the next bit, just in case, I felt like it was important to know how familiar are you with protein structures before I kind of just throw words at you. Could you take a minute to tell me whether you know they exist, you vaguely remember them doing them in like school at GCSE, or whether actually you can teach me about protein structures, which is very likely. Like if any of you know a lot about it, this is not my area of specialty. Just because prion infection is intrinsically linked to protein structure. Cool. I'm aware it exists is kind of where I was comfortable with being. So I'm glad that we're all in that space and that you're not going to tell me that I've explained this to you incorrectly by going, I teach this and you're an absolute idiot. That's not how I talk about a beta sheet. So my infection control nurse in my team drew these and I love them, so I'm going to use them at every possible talk. Fundamentally, what we're talking about is things like hydrophobic and hydrophilic proteins. If you have a hydrophobic protein, you ain't getting it off the surface using stuff that's water once it's dried. Because its conformational structure will just be like, not doing it. Prions are about the most hydrophobic proteins you can get. So if you have surgery and you have somebody that is got prion protein present, and most of the time you will never know that, then once it is dried onto that surface, you're not removing it. It's there. And we're going to talk about why that's important. So, protein, you've got your amino acid chains. They turn into what we call secondary structures. You do not need to know much about this, but the important thing is to know that you have alpha helixes and beta sheets. And they affect how hydrophobic and hydrophilic your protein is. They affect how that protein works in practice. And your drying times can impact on what proportion of beta sheets versus alpha helixes you have. So your proteins are not stable over the course of your drying time. So your drying time at 8 hours leads to something different to your drying time at 72 hours. And so it's not just whether you're keeping something moist or dry, it's actually how long you're keeping it moist or dry that is really important, because you'll start to get some of these conformational changes within about 15 minutes of something being used. I put this up in case anybody is very excited by this topic and wants to read it more, but you do not need to know much about it. But the big thing is this gives you an illustration of how over time you lose your water, your albumin will change, and therefore all of your structures will change. And so you actually get change in molecular weights, which mean that those things become harder to remove. And so it's not just that visible dry, visible sticking. There's a whole load of process behind this that changes the risk if you don't manage to maintain it nice and moist and keep that water in there, because it's keeping that water in there that makes the difference. So you've all heard of VCJD, right? So there were actually 4 different main types of presentation of CJD. Genetic is like your familial, so you have it often within families. You get odd sporadic cases. Most of our surgical instrument transmissions actually come from sporadic versus VCJD, but that's because actually we probably may not know what the extent of that is for some time yet. When were you born? I had to ask this question because I spoke to my PhD student on Friday and I was slightly horrified by the answer because he doesn't remember any of the stuff about BSc. So I felt like I needed to just check in to see where we're at. Okay, fine. We're all good people. We don't have to have this conversation. We're embracing our age. I was mortified. He also was like, so what was it like to be alive in the 80s? I was like, screw you. Thank you very much. It was brilliant. Thank you. So 1996 is a really important cutoff for people like me who work in pediatrics, or used to be, because that's when we counted people as exposed or non-exposed in terms of our instrument sets. So variant CJD emerged late 80s, early 90s. It was linked mostly to BSc in the food chain. The highest number of deaths was in the 2000 with about 28. But the big thing to note is the data's quite variable because it's all done on things like appendectomy, tissues, tonsillectomy tissues, that kind of thing. So you've got a wide margin of error, but it could be that up to 1 in 2,000 people is carrying a form, and there are different presentations, whether you're heterozygous, homozygous, of prion protein in some of their tissues. No one really knows what that risk equates to. Honestly, there's a lot of speculation that, like, the increasing rate in Alzheimer's could be linked to some of the presentations of prion protein. But I think if anyone told you categorically they knew what those numbers meant, I think I would question. But it means that actually we do a lot of surgery in this country, and we do a lot of surgery on a lot of different people. And so the chances are that there will be instruments that are going through that pool that you won't know have been used on somebody with this kind of prion protein present. And there have been identified transmissions, often linked with high-risk tissues, but obviously things like human growth factors, those kinds of things, that we know that this is a risk. And there have also been studies on things like primates where we have taken tissue that has sliced into a primate presentation and passed it through, and actually seen that you then get presentation of symptoms. The reason this is all important, and the reason that thing I told you about hydrophobic proteins is important, is that although people talk about prions acting like viruses, it's both true and it's not true. So prions induce a conformational change in the protein that's next door to them. That is, we all have prion proteins, right, on our neurons and things. We have them. The prion disease proteins have a different shape. So they change from these alpha helices to having this beta sheet. And so you move from having a normal prion protein that is about 3% beta sheet to having a prion protein that is up to about 43% beta sheet. So that means that it becomes really resistant to sterilization. It is really hard to remove. It's super hydrophobic, and it spreads by changing the prion protein next to it. So if you have a prion protein on your surgical instrument that if used to slice into someone's brain, and it is not removed, and you use it to slice into someone else's brain, even if you've sterilized it and gone through all of that, then you are putting a prion protein, a prion disease protein, next door to a standard protein, and that can induce a conformational change and therefore pass on the infection. So it's not your standard infectious process. No one knows how often this happens, really. No one knows the risk of this, but we do know that it does happen, and how much that's associated with loading. So it's just really worth being aware of. That's why this stuff is important, because you can do it all right and still have this risk. So what can we do to reduce this risk further? And the big thing you do is they're really hydrophobic, so you put them in water and therefore they won't adhere. So if you maintain moist, you're stopping that instrument adherence in the first place, because once it's there, really hard to get rid of. And so basically you get this cascade effect where your prions change, you then get areas of necrosis that then causes the disease presentation. The guidance therefore says here that you should be doing moist transportation for your high-risk tissues. In Scotland, they say you should be doing it full stop. So it kind of depends on where you are. And how that has come about is it's been very much an economic evaluation of risk. So the HTA, so the Health Technology Assessment from the NIHR, basically says it is not good value for money to split instrument pools anymore because of the very small number of cases we actually detect. The best way to do it is to stop it happening in the first place, and that's by using a spray bottle that costs you about £3 versus buying an entirely new instrument set for your patients that were born after the risk. So if those of you who use moist, do you know which one you use? Many of you didn't really know that whether you use moist or not, so we may skip over this. we've used sprays. We evaluated kind of humid packs and stuff. We felt like sprays were easier. Humidified packs kind of felt like they had quite a lot of risk if people didn't seal them properly. Cool. Here's a question. When you wrote your SOP, I'm asking this because I did not write this, did you say how people spray? Because it wasn't until I read a paper over the weekend that I was like, oh, well, that's a good point. Do you spray evenly to try to decrease all risk? Do you focus some of your spraying on your high-risk areas in terms of where you're going to get drying, so hinges and things? Or do you just go random? I think random is probably not what I would support. I would think I would support even. But I think a lot of things like SOPs will not include that data set. For those of you that are still dry, I felt like I should really finish by going, yes, I think moist solves a lot of your issues. But there are other decisions to make. So if you are not dealing with high-risk issues, if you are not in Scotland, if you are somewhere else in the world where you don't need to use moist, you need to really be thinking about your cleaning agent. So this paper here shows you that your removal very much depends upon your cleaning agent, because all of them will have different properties to be able to, when I talk about rehydrolyzation, about surfactants that will pull stuff off surfaces, all of those will vary a lot depending upon your cleaning agent. And so if you are not going down a moist route, then you need to at least think about how you use your dry. So what are you putting in your washer disinfector? Do you need to do any pre-steps for anything that you think about as high risk in order to actually still feel like you're maintaining your safety? But bear in mind, none of these studies are going to be on super hydrophilic proteins, because otherwise they can't measure them. So that's probably not going to get around your prion risk. So if your prion risk is what you are trying to avoid, there's probably only one route for it. So we're going to finish. I think I'm kind of on time. 1 minute over, I'm so sorry. With kind of thinking about how you now feel about moist. Like, has it changed how you feel about it?